The median, ulnar, and radial nerves course through the forearm and wrist, and they help coordinate the movement of our forearms and hands. These nerves, however, are prone to injury because of various causes, and depending on which one of them is injured, that will result in characteristic symptoms that can help us recognize and identify it. For the median nerve, the clinical manifestations depend on whether the lesion has occurred distally, as in carpal tunnel syndrome, or proximally, as in an anterior displaced portion of a medial supracondylar humerus fracture. The most common cause of median nerve injury is carpal tunnel syndrome, which is when the tunnel in the wrist through which the median nerve passes becomes narrower and compresses the median nerve. This can happen due to repetitive use, like typing on a keyboard, injuries like an anterior lunate dislocation, or it can be associated with conditions such as hypothyroidism, diabetes, or in pregnancy. Symptoms of median nerve injury would be pain and paresthesia in the radial 3.5 digits, weakness of the first and second lumbrical, thenar atrophy, and weakness of thumb abduction and opposition of the affected hand. Specifically, the recurrent branch of the median nerve is what provides motor innervation to the thenar muscles of the hand, which are responsible for abduction, flexion, and opposition. So with injuries, people may have issues opposing the thumb, and it may be difficult to perform actions like buttoning up a shirt. Damage to the recurrent branch of the median nerve alone causes what is known as ape hand, which refers to atrophy of the thenar eminence and inability to oppose the thumb. Damage to the entire median nerve at the level of the wrist presents clinically as a median claw. Let's break this down quickly. So the first and second lumbricals are innervated by the median nerve, and the lumbricals normally flex the metacarpophalangeal joints and extend the distal and proximal interphalangeal joints. If the median nerve is injured, the opposite occurs. So at rest, or when the patient tries to extend all the fingers, the index and middle fingers stay extended at the MCP, and the DIP and PIP stay flexed, especially since the finger flexors are unopposed, resulting in the median claw. Now, in a proximal lesion to the median nerve, as in a supracondylar fracture, we have all of the same deficits as in a distal lesion. But now, all of the finger flexors of the second and third digit are also affected, such as the flexor digitorum superficialis and the lateral half of flexor digitorum profundus. So when an individual is asked to make a fist, they can only flex the fourth and fifth digit, and this presentation, or claw, is referred to as Pope's blessing, or hand of benediction, and it is indicative of a proximal median nerve injury. Okay, next, there's ulnar nerve injuries, which can occur anywhere between its origin from the brachial plexus to the ulnar canal or Guillain canal in the wrist. Most commonly, it's associated with elbow injuries, such as fracture of the medial epicondyle of the humerus. In a distal ulnar nerve injury, like a fracture to the hook of the hamate bone, or when cyclists compress the hook of the hamate bone when holding onto handlebars, there's numbness and sensory loss to the medial 1.5 digits, weakness in abduction and adduction in digits 2 to 5, weakness in the adduction of the thumb, weakness in flexion of the fourth and fifth digits and opposition of the fifth digit, as well as hypothenar eminence atrophy. It also manifests clinically as an ulnar claw. This is the exact opposite of the median claw, where this time we have paralysis of the medial 2 lumbricals. So at rest, or when the patient tries to extend their hand, the ring and pinky fingers stay extended at the MCP, and the DIP and PIP stay flexed, and the finger flexors are once again unopposed. Okay, so in a proximal lesion to the ulnar nerve, as in a medial epicondyle fracture, trauma, or prolonged leaning or sleeping on your elbow, we have all of the same deficits as in a distal lesion. But now there is the additional problem that we have lost function of the flexor digitorum profundus on the medial side. So, when a patient is asked to make a fist, they can only close their second and third digits or fingers, and this is called an OK gesture. Additionally, there is a loss of flexor carpi ulnaris resulting in wrist adduction deficits. So, when they try to flex their wrist, it deviates radially. Finally, radial nerve injury can happen a few different ways. First off, it can occur by repetitive pronation and supination of the forearm, for example, when using a screwdriver. In this case, it manifests clinically as finger drop. This occurs because the deep branch of the radial nerve pierces the supinator muscle as it travels distally, and overuse of supination can cause impingement here. After the supinator muscle, this branch goes on to innervate the extensor indices, so reduced function of this muscle can result in a finger drop due to weakness of the finger extensors and unopposed action of the finger flexors. Radial nerve injury can also occur because of a midshaft fracture of the humerus, or because of a lateral deviation of a displaced supracondylar fracture of the humerus. This manifests clinically as weakness of the supinator and extensor muscles of the wrist and fingers, as well as sensory loss to the posterior forearm, dorsolateral hand, and dorsal thumb. The classic clinical finding is wrist drop, which is when the wrist hangs in a partly flexed position on account of unopposed wrist and finger flexors. Finally, it can occur due to compression of the brachial plexus, for example, when using crutches or sleeping with your arm hanging over a chair, hence the term Saturday night palsy. Since this injury occurs superior to the branches of the triceps brachii, this also causes paralysis of the triceps, leading to loss of elbow extension in addition to loss of wrist and finger extension. There will also be loss of sensation over the dorsal hand and thumb, as well as the posterior forearm or arm, depending on how high up the nerve damage is. Alright, as a quick recap. The median nerve, specifically its recurrent branch, can be injured at the level of the wrist, resulting in atrophy of the thumb and an inability to oppose the thumb, called an ape hand. Injury to the entire nerve at the wrist results in a median claw, which is when the index and middle fingers stay extended at the metacarpophalangeal joints, while the distal and proximal interphalangeal joints stay flexed when trying to open the hand from rest due to weakness of the lateral two lumbricals. Proximal median nerve injuries have the same deficits as distal injuries, plus additional weakness of the forearm muscles innervated by the median nerve. This results in a clinical finding called Pope's blessing, or the hand of benediction, when an individual is asked to make a fist, and they can only close their medial two fingers. Ulnar nerve injuries distally at the wrist result in numbness and sensory loss to the medial 1.5 digits, weakness in abduction and adduction in digits 2 to 5, weakness in adduction of the thumb, weakness in flexion of the 4th and 5th digits and opposition of the 5th digit, as well as hypothenar eminence atrophy, plus the characteristic ulnar claw, which is the exact opposite of a median claw. A proximal ulnar injury has the same deficits as the distal injury, as well as weakness of wrist adduction and flexion of the medial 2 digits, and also results in the OK gesture. Finally, radial nerve injury may result in either finger drop, wrist drop, or Saturday night palsy, as well as sensory deficits to the dorsal hand and thumb, forearm, and arm depending on the mechanism and location of the injury.